Good morning, Stephen. Good morning, friends. Good morning, colleagues. It's great to be with you today, this morning. I was supposed to fly all the way to Johannesburg, but unfortunately we have holiday season, and I will probably be divorced very soon if I came to South Africa again within 2 months, because as some of you know, I've just been to Cape Town in May, and it's really a great pleasure for me that you give me the opportunity again to speak in a national meeting about Uro-Oncology. The topic you gave me is a surgical one, which is something that I appreciate because at the end of the day, I'm a urologist and I'm a surgeon. So that's basically also my only disclosure that I have to make for this talk. I'm a surgeon, so I'm biased, and I'll say that again. Very briefly touch upon the guidelines. We are mainly referring to the EAU guidelines for the treatment of localized prostate cancer because it's a comprehensive guideline, and we don't follow as much the national guideline, but more the EAU guideline. And as all of you know, treatment of low-risk prostate cancer has significantly changed in the past 10, 15 years, and it's mainly a domain of active surveillance. And I'm not going to touch upon active surveillance a lot, but the patients that we used to operate on 20 years ago for or doing a radical prostatectomy in were mainly those with low risk and low intermediate risk cancer that we are now performing active surveillance for. I'm mainly focusing on intermediate risk prostate cancer as well as on high risk prostate cancer, and you will see that the two of them are slightly different from a surgeon's perspective. And as you know, there is a strong recommendation to offer radical prostatectomy to patients with localized intermediate risk prostate cancer if their life expectancy exceeds 10 years. And there is also a strong recommendation to perform either brachytherapy or intensity modulated radiotherapy as an external beam radiation. So in fact, both technologies are kind of rivals, and it's always a fight between the two of them. And I'm trying to convince you that surgery is a very good option in most cases if you are a dedicated surgeon. As I've already said, my bias is clearly for surgery, and I'm a surgeon. I believe in surgery, and that's why I am trying to convince you that surgery in many ways, in many situations, is a good choice. The only thing that you have to do is you have to do it well. And I'm also trying to give you a few hints on how to perform a radical prostatectomy in a sleek and elegant way with a good result for your patients. Well, firstly, there has been numerous studies, meta-analysis in the past 10, 15 years comparing radiotherapy to radical prostatectomy in clinically localized prostate cancer. This is one of them. It's not a very new one, but I think it's a very comprehensive one. It's including almost 120,000 patients out of 19 trials, and it's specifically looking at overall mortality and prostate cancer-specific mortality in radical prostatectomy versus radiotherapy. And it's a good study in a sense that it's showing a clear trend for radical prostatectomy in all studies. And this is true both for overall mortality, which is usually confounded by the fact that radical prostatectomy candidates may be those that are in better general health, but they are also positive, or the forest plot also trends towards the radical prostatectomy arm for patients regarding prostate cancer-specific mortality, which I think is a stronger argument for radical prostatectomy in clinically localized intermediate-risk prostate cancer. So in fact, there is an obvious trend that we can decrease the risk of all-cause mortality, but also prostate cancer-specific mortality in all patients. And even if we adjust to all known risk factors such as age, cardiovascular risk, and so forth. So it seems to be really the intervention itself that is causing a bit of a difference in the long term, in the long run specifically. Well, speaking about the two different options, you clearly have to understand that both have a different side effect profile and a different risk profile. So take, for instance, urinary incontinence. And urinary incontinence used to be a problem for radical prostatectomy, and it's believed to be around 10 to 20%. And it's believed to be lower in radiotherapy, at least if we refer to stress urinary incontinence. I'm not so sure if we refer to overactive bladder and urge incontinence. I think that probably the rates there, especially in the long term, are definitely equaling rates of 10 to 20%. Regarding erectile function, also one of the negatives of radical prostatectomy in this study, which is a SEER analysis, it was shown to be around 60 to 70% at 1.5 years, which is probably too high. And it's also acknowledged that nerve sparing, of course, does make a difference. And in radiotherapy, I think it's also important to state that after 2 years, there is also an erectile dysfunction rate of approximately 60%. So obviously, no difference in the medium term for both interventions. Looking at other complications such as urethral stricture, there is a trend for more strictures after radiotherapy. There is a significant trend for more cystitis, radiogenic cystitis after radiotherapy, and there is a significantly higher risk for rectal toxicity following radiotherapy to the prostate for intermediate risk prostate cancer. When looking more specifically at the outcomes of robot-assisted radical prostatectomy, which is nowadays the standard of care, I believe we can see better continence not only in the short term, so about 2/3 of the patients are continent 3 months after the procedure, but even 95% of the patients are continent after 2 to 3 years after the radical prostatectomy. Likewise, there is a significantly quicker and better recovery for erectile function when it comes to full nerve-sparing robot-assisted radical prostatectomy. So I believe it's a good technique and it's something that you could consider in certain patients. In some patients, which I would call must patients, radical prostatectomy is definitely has many advantages over radiotherapy. Specifically, men aged younger than 55 years is definitely, from my understanding, a radical prostatectomy candidate because we don't know too much about long-term toxicity beyond 15 to 20 years after radiotherapy with curative intent, especially when you look at the very high dose that we use at the moment. Obviously, patients who had prior radiotherapy to the pelvis are not candidates for radiotherapy. The presence of chronic inflammatory bowel disease, which is not too rare, may also preclude the patient from radiotherapy. Hemorrhoidal disease, rectal disease, very large prostates beyond 100 cc are probably not good candidates for primary radiotherapy because of the volume and the high risk of overactive bladder and urge incontinence. Certain subtypes of localized prostate cancer, such as ductal histology, are obviously better candidates for radical prostatectomy as opposed to radiotherapy, and also a history of bladder cancer and potentially also rectal cancer may render the patient as a candidate for radical prostatectomy rather than radiotherapy. So let's talk a bit more about quality radical prostatectomy. A quality robot-assisted radical prostatectomy has 3 aims. First of all, cure of cancer, preservation of potency, and preservation of continence. And if you're able to preserve all the 2 of them while curing cancer, I think you've done a very good job. And there are some recommendations or ways to achieve this trifecta outcomes for radical prostatectomy, and it's of course a very precise understanding of the anatomy within the pelvis to understand in particular the vascular anatomy and the neurovascular anatomy around the prostate. And also it's important to understand that the neurovascular anatomy may be the same in every patient, but its presentation differs from patient to patient. So you always have to sort of adapt your strategy to the individual patient anatomy. Obviously, it's relevant to preserve blood supply for any type of reconstruction, such as the vesicourethral anastomosis or the posterior reconstruction using a Rocco stitch. Again, experience matters. If you have done a few thousand, it's better than just a few hundred, and there is still a learning curve even after 5, 6, 7, 8,000 procedures. And my personal understanding, my personal belief is that there is a single best technique out there, which is the posterior approach or Retzius sparing, which is giving the best possible continence outcomes, especially in the short term, but also in the long term. In terms of technology, we've been using the NeuroSafe protocol for a long time. So intraoperative frozen section analysis of the surface of the prostate that is neighboring the neurovascular bundle. It clearly helps to optimize your outcomes. Recently at the EAU this year, the NeuroSafe proof trial was presented that nicely showed that if you perform nerve sparing based on intraoperative frozen section, not only the risk of positive margins is lower, but also the outcome parameters such as erectile function and continence are clearly better compared to a non-NeuroSafe approach. So I believe in a very near future this is going to be the standard, probably in most developed countries performing radical prostatectomy for intermediate risk and especially for high-risk prostate cancer. As I already mentioned, Retzius sparing technique or the Retzius sparing approach is a very nice one. I'm sure many of you have seen it. The beauty of it is that it can only be done using the robot. It can't be done openly, and it's an approach that is preserving almost all the anatomical structures that are relevant for continence and also for erectile function. So it has become our default approach, I would say, for 99% of all radical prostatectomies done in an intermediate risk situation. And the data out there clearly supports this approach. There is an absolute trend for the posterior approach to offer better continence outcomes within at least the first 6 to 8 months after surgery, and especially within the first few weeks after surgery compared to the standard anterior approach. And it takes almost a year until both curves are approximating, reaching virtually the same levels of continence after radical prostatectomy. So if you want to render your patient continent straight after surgery, then probably the posterior approach is the one that you should look for. Also, when looking at other outcome parameters such as sexual function, because it has always been criticized quite a bit that we might use a bit more energy in the posterior approach, there is no difference when it comes to sexual function comparing the anterior and the posterior approach. And probably the biggest advantage of the posterior approach is preservation of continence, which is usually one of the biggest sorrows that patients have before definitive treatment for localized prostate cancer via radical prostatectomy. For many years, we haven't quite understood why the posterior approach is giving better results. And this study has, I would say, shed some light onto this problem. It's a Japanese study that did something very simple. It compared dynamic MRI, pelvic floor MRI, pre and post-operatively for radical prostatectomy patients, comparing directly the anterior approach compared to the posterior approach. And it was nicely shown that the bladder position remains much more stable after the posterior approach compared to the anterior approach, and that it almost takes 1 year for the bladder to get back into its original position, and until it's finally making the same pelvic floor, until the patient is having the same pelvic floor movements as he had before surgery. So preservation of anatomy is not only for the sake of aesthetic surgery, but it's also for the sake of preserving a natural pelvic floor motion. So another piece of evidence for the posterior approach. Looking at high-risk prostate cancer, and I would say this is a different story. High-risk prostate cancer, especially those with very high-risk prostate cancer, are different patients. Their risk of relapse is significantly higher, and it is not or it is commonly accepted that radiotherapy plus androgen deprivation therapy for 2 to 3 years is considered the standard of care, and that radical prostatectomy as part of a multimodal treatment may be an alternative in selected patients. And I want to here give you a bit of a perspective on what might happen in the near future. And as I've already said, the problem with high-risk prostate cancer and radical prostatectomy is that the risk of biochemical relapse is significant. 50% of the patients with high-risk prostate cancer undergoing radical prostatectomy have a biochemical relapse after 1 year, which is significantly too much. And at the same time, you have a significant number of patients that are being diagnosed with high-risk prostate cancer. So we face a significant challenge handling patients with high-risk prostate cancer. And even though, as I mentioned, the radiotherapeutic approach is considered the standard of care, you will definitely see patients that are not perfect candidates for primary radiotherapy, but you would still consider surgery. And at the same time, we perform surgery at current standards without the use of adjuvant or neoadjuvant androgen deprivation therapy. And I believe that this is the strongest sort of leverage between the two approaches. And that's why also the short-term outcomes or medium-term outcomes of radiotherapy may be better because of the influence of concomitant androgen deprivation therapy. And this is, for instance, a very recent study comparing radiotherapy to radical prostatectomy in high-risk patients. And it's shown that within the first few years, there is a difference in metastasis-free survival between radiotherapy plus ADT versus radical prostatectomy, which is, in my opinion, not very surprising because radical prostatectomy goes without ADT in the first place. But if you look at overall survival, there is no difference between the two groups. So obviously, the confounding risk or the confounding factor ADT plays a very big role in the treatment of high-risk prostate cancer and in comparing surgery versus radiotherapy. In this sort of field, I believe the use of neoadjuvant or perioperative novel androgen deprivation treatment is going to be a game changer soon, because then we are actually having the same weapons. We use a curative treatment, which is accompanied by a perioperative or peri-interventional androgen deprivation and deep androgen receptor pathway inhibition. And then there is data out there from current trials that show that if you are using novel RPs, for instance, in the context of radiotherapy, there is a significant number of patients with complete pathologic remission or response in their radical prostatectomy specimens, which is a very important prognostic sign. So there is definitely an indication that perioperative treatment may be beneficial. And hopefully this year or by the beginning of next year, we'll finally answer the question whether neoadjuvant and adjuvant ADT plus apalutamide will be a game changer in the field of the treatment of high-risk prostate cancer. The Proteus trial is read out for a long time, and the only reason why it's not yet reported, I suppose, is because there are not enough events, which is actually a good sign. But I hope there will be changes for us surgeons to have better weapons in the field of high-risk prostate cancer. As a surrogate for efficacy, we are currently using pathologic complete remission. So if there is no more cancer found in the radical prostatectomy after neoadjuvant treatment, outcomes are excellent. Patients will remain metastasis-free at 5 years in 80% of the cases, which is fantastic. And there is even a very, very good metastasis-free survival rate in those that are achieving a complete pathologic complete remission, reaching almost 100% if you subgroup the patients even more. And on top of this, there may be an opportunity for us as surgeons, but also clinical oncologists, to get a better understanding of androgen receptor signaling and its impact on clinical disease outcomes, sort of a potential for translational research, and in fact enabling us eventually to provide a more patient-tailored therapy depending on certain factors after a run-in phase with an androgen deprivation plus or minus androgen deprivation, androgen receptor signaling inhibition. Finally, and this is sort of the last part to conclude my talk, certain patients that we operate on for high-risk prostate cancer, even though we don't want this, and even though we want to avoid that, and even though we use modern molecular imaging to rule out nodal disease, some patients still have pathologic lymph nodes after radical prostatectomy, and for them, treatment is not 100% clear. There are three options. One is to offer adjuvant ADT. The other one is to offer expectant management, especially in patients who reach a nadir of less than 0.1 after 6 weeks post-surgery. And if patients have a low disease burden, so I believe for them observation is definitely a good choice. And finally, adjuvant ADT in conjunction with radiotherapy to the pelvis in patients with high volume nodal disease. And data suggests that there is a potential role for adjuvant ADT in certain patients who have node-positive disease after radical prostatectomy. This one was published in The Lancet a few years ago, showing an effect for immediate ADT despite being a small study, and its impact on sort of a larger community may be limited. It's still a good trial, and it still shows that there are certain patients benefiting from early ADT. And also, there is some evidence that early intensification in patients with high volume disease in their lymph nodes is a good idea. So it's essentially combining ADT plus radiation of the pelvis. And again, you can see here in two studies, one is a bit older from Sweden, the other one is the Briganti trial, which is well known, whereby we see a benefit for in treatment intensification. So in conclusion, my opinion, and also data corroborates that in a sense, is that radical prostatectomy by itself prolongs life in patients with localized prostate cancer. Overall survival and cancer-specific survival clearly favor radical prostatectomy as a primary treatment. There are certain patients that, in my opinion, as a urologist, have must indications for radical prostatectomy. The modern techniques that we use nowadays give us excellent functional and oncologic results. So it's important to keep that in mind when counseling patients. It's also important to keep in mind that radiotherapy has a potential for significant long-term morbidity. And also there is a potential for multimodal treatment for advanced disease, especially if prostate cancer is associated with significant outlet obstruction or bleeding or local complications. and still we have a lot of work to do to do a better patient selection in order to improve our outcomes, in order to improve patient allocation. And with that, I want to thank you very much for having me once again. I'm looking forward to be with you again in person and to have a few drinks with you guys together because it was a great experience back in Cape Town. Have a wonderful meeting. I'm open for your questions. Thank you.